Good afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on It's Not Just COVID-19 Anymore, the update on influenza for the 2021 to 2022 season. My name is Andrea Saunders, and I'm a communicable diseases specialist at PHO, and I have the pleasure of moderating today's session. Before we begin with today's presentation, I have a few housekeeping items to mention. Following the presentation, there will be a question and answer period. So if during the session you have a question that you would like to ask, please enter it in the Q&A pod at the bottom of your screen. The chat pod has been disabled to limit any distractions during the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as the moderator of this session, I do not have any potential conflicts of interest to declare. It is now my pleasure to introduce the speakers for today's presentation, Drs. Michelle Murdy and Dr. Jonathan Gabay. Dr. Murdy is a medical director in the Health Protection Department at Public Health Ontario. Her areas of expertise include communicable diseases, surveillance and epidemiology, and emergency preparedness. She is cross-appointed in the Dalla Lana School of Public Health at the University of Toronto. Dr. Gabay is a medical microbiologist at the Public Health Ontario Laboratory and a pediatric infectious diseases physician. He has been the medical lead of many key programs at PHO's laboratory, including respiratory viral infections, emerging viruses, respiratory bacteria, and gastrointestinal viruses. He holds an academic appointment at the Department of Laboratory Medicine and Pathobiology and the Department of Pediatrics at the University of Toronto. And with that, I will hand it over to Dr. Murty.
Thanks so much, Andrea, for that introduction, and welcome to today's rounds presentation. So last year, when Jonathan and I presented, we were really heading into a season of really mostly only COVID. So this year, we're interested to speak to you today about preparing for a potential influenza season in the coming year, but also that it's not just COVID anymore. So neither Jonathan or I have any conflicts of interest to declare. And to recap the objectives for today's session. So today's session is to describe trends in influenza and respiratory activity observed following reopening phases of the pandemic in Ontario, Canada, and internationally. Describe influenza vaccine products available as part of Ontario's universal influenza immunization program for the coming year. Understand the use and benefits of antiviral medications for the treatment and prevention of influenza, and understand influenza and other respiratory virus laboratory testing for the 2021-2022 season. So we can bring up our first polling question. The question is, how many laboratory confirmed cases of influenza were reported in the 2020-21 season in Ontario? Well, seeing a good mix of answers coming in, so almost even split across the four options. So the correct answer is actually less than 30. So those who picked a 10 to 49 got the correct answers, which actually was the highest voted one. So I guess people were very aware that we had a very low influenza season last year. So just as a quick recap of what did happen last year in the 2020-21 season, both in Ontario as well as in Canada. So as mentioned, we said we had less than 30 laboratory confirmed cases of influenza in the province last year, which is obviously far, far lower than what we would normally expect for a typical influenza season. And we weren't necessarily not looking for influenza. In this graph, we can see the yellow bars as the weekly number of tests for influenza that were occurring through the last year. And so, the typical winter months, we were seeing as much as over 1,600 tests a week. So we were looking for influenza, but we weren't really finding it either for influenza A or influenza B. And that was true for most of the other respiratory viruses, which we can test for in multiplex testing that Jonathan will be speaking to later. We saw very low activities for adenovirus, human metapneumovirus, parainfluenza virus, human seasonal coronavirus, as well as respiratory syncytial virus. The only one that we really saw more typical seasonal activity for was in that blue line here, the enterorhinovirus, where we had last fall, and then the usual time that enterorhinovirus would be circulating, more typical activity. And again, now we're seeing, as we're heading through the end of the summer and now into the fall and the start of the new 2021-22 season, we're seeing a repeat increased activity of enterorhinovirus with as close to almost 30% positivity in the province, and also seeing a bit of an unseasonal increase in recent weeks for para-influenza activity. What we see in the community also translates to what we can see in terms of outbreaks in institutions. So institutions would primarily be long-term care homes, as well as some retirement homes and hospital outbreaks. So here in this graph over the last season, the purple here is predominantly COVID outbreaks, not necessarily all COVID outbreaks, it's COVID outbreaks that would meet definition for a long-term care outbreak. But here you can see that the spillover from enterorhinovirus activity in the community in the fall of last year and this year is now entering long-term care homes and other institutions in the province in these little pink bars at the bottom last season, as well as this coming fall. And then also the chance of having multiple infections within the same outbreak. The little blue bars last season, as well as now starting this season, are outbreaks where we might have a mixed picture of 2 or more organisms within an outbreak. And so that's one of the key things we're looking for potentially this year with both COVID circulating, as well as now other respiratory viruses potentially circulating. So Ontario is certainly not unique in terms of what we saw last year. This is a bit of a snapshot from respiratory virus activity across the country over the last year. And so nationally in Canada, we saw, again, similar very low rates of most of the respiratory viruses, with the main exception of enterorhinovirus showing more typical seasonal peaks, although still lower than typical seasonal activity that you can see in the gray line here. So lower than what would be typical for the season, but at least some activity. And then a little bit of, again, unseasonal, a little lower human parainfluenza virus activity. So at this time of year, we also typically would turn to other parts of the world to understand what might be happening in our summer and other places' winter. So in the Southern Hemisphere, what's going on for the winter season that they've just now coming out of. And what we're really seeing from there is actually there's not a lot of influenza activity even circulating globally. So this is WHO influenza surveillance overall across both Northern and Southern Hemisphere over the last year. So we're seeing very low influenza activity with a little bit of increasing in the last few weeks and a bit of a mix again between influenza A of mostly H3 and some Victoria lineage of influenza B. Essentially, we would typically think that this is going to come from the winter areas that are having their winter when we're having our summer. So when we look to the Southern Hemisphere, it's actually not where we're seeing the influenza activity. The Southern Hemisphere has reported very low influenza activity throughout their winter months. And specifically looking at Australia, where we typically look for some of their influenza surveillance over the winter. Again, they've had almost a 0 year for influenza activity compared to previous years. So where is the current influenza activity happening across globally? We do see some influenza B activity happening in Eastern Asia, and then more recently, influenza A H3 activity happening in Southern Asia. So we do have some indication that yes, possibly influenza could be coming and circulating within the Canadian context. There could be new importations and spread, but really still so far very low levels of influenza compared to what we would normally be seeing. So what's the challenge then for us for this year? When we have this little information from an international context, that really strains our ability to actually make predictions about what's going to happen for a 2021-22 season. It influences our ability to say, we don't actually know what specific strains might circulate if they are going to be circulating. We have some indication that it's an H3 that's dominating in Southern Asia. That could be the case for a Canadian context, but it could also be a bit more of a mixed picture depending on what might actually get introduced and circulate. We also have less information in terms of determining how well influenza vaccines worked last year. With such little influenza activity, we weren't able to generate the typical vaccine effectiveness estimates to say how well are we working. how well is influenza vaccine working last year, both in the Northern Hemisphere as well as the Southern Hemisphere product, to be able to inform how well it might be working for the coming year. Although to say, we are starting to see some few influenza detections within the Ontario context, both travel related as well as non-travel related. So certainly still expecting to see some influenza activity this coming year. There's also some modeling studies to suggest that we might be actually having a larger than typical influenza season as somewhat of a rebound effect for the fact of not having influenza circulate over the last year and a half. So these two preprint studies have some different modelings where they're both showing almost a larger than expected influenza season potential for the coming year, unless other compensatory mechanisms are in place, like increased influenza vaccine uptake and coverage. One of the papers also did, really point out to say that, who might be most affected is some of the youngest children who really are relying on influenza vaccine immunity because they haven't actually been exposed to influenza virus in their lifetime, if in the last year and a half when the influenza hasn't been circulating. So as mentioned, our title of talk it's not just influenza that we're worried about this year. We have had some signals that it is increased RSV or respiratory syncytial virus activity that we should also be paying attention to in terms of impacts on healthcare and severe illness in young children for the coming year. So we've seen since about the end of 2020, some interseasonal RSV activities happening internationally. Australia had a very large interseasonal outbreak in their summer months at the end of 2020 and the beginning of 2021. Similarly with France, they had a delayed RSV season about 4 months later than would typically occur for France, and associated with that a very high incidence in severe outcomes for young children with that RSV outbreak. And then similarly in the US at the beginning of the summer in June, they issued an RSV alert to their clinicians due to the high interseasonal activity of RSV. And that's not just internationally, but also within Canada. Quebec, amongst the provinces, has also experienced a similar increase in RSV activity outside of a typical season. You can see here on the graphs on the left that the red line of Quebec is the only one that where RSV has now suddenly increased over the summer months into the fall, getting as high as about almost 30% positivity for RSV, whereas the rest of the provinces and territories have not experienced a similar RSV increase in activity. And that this unseasonal activity is definitely putting a strain on the system. So we definitely would expect from a healthcare planning perspective, a typical respiratory season through the fall of high RSV as well as other respiratory virus activity impacting the number of admissions to emergency rooms and hospitals for young children. But now seeing that an interseasonal period makes it more difficult to determine planning for when we might be seeing this type of activity. And so similarly, in recent weeks, we are starting to see that increase in activity within the Ontario context. This is a table from the Public Health Ontario Laboratory Weekly Report. You can see down here that in the most current week, week 37, for children under the age of 1, there was a 41% positivity for enterorhinoviruses, of which the vast majority are actually rhinovirus. We had an almost 10% positivity for parainfluenza virus and an almost 18% positivity for RSV. So certainly starting to see an increase in these other respiratory viruses at this fall period of time. That also carries through to the next youngest age group, the 1 to 4-year-olds, and then starting to see a bit more of a mixed picture in the 5 to 19-year-old groups. But really, if you're one of the parents who've now recently sent back your child to school and have had symptoms and had to go get a test, it's probably at this point, especially in this youngest age groups, more likely to be due to one of these other viruses rather than COVID-19 at this point. So again, what does this mean for an anticipation of a 2021-2022 season in Ontario? We are expecting that other viruses, as they are now starting to circulate, will continue to circulate through the fall period and into the winter. We do expect, though, that given that a number of public health measures are still in effect in Ontario, we do have continued indoor masking, continued physical distancing, and other public health measure behaviors that individuals are taking on because of COVID, we do expect some dampening of circulation of these viruses given these other measures. However, we are mostly concerned about the fact that we've had a reduced population immunity for a year and a half of not being exposed to these respiratory viruses, which may impact, of course, the youngest children who really would be normally exposed and developing their immunity at this point, which has implications for both the need for vaccination as well as potentially other healthcare planning for the youngest children who might be affected. So I'm now going to switch gears a little bit to tell you more about what's coming forward in terms of the influenza vaccine products that we have available for the 2021-2022 season. So here's the summary of the change in the strain selection for the 2021-22 season North American vaccine products. So we have had a change in both the H3 and the H1 components for the egg-based as well as the cell-based product this year compared to the vaccine from last year, whereas we have the same virus selection for both the B strains that are available in the quadrivalent products. And we do have, again, cell-based product available within Ontario this year. So we do see a slight difference of they use the same H3 strain, but a slightly different H1 strain for the cell-based product just based on better growth within that cell line. So for our universal influenza immunization program in Ontario, we actually have a total of 6 products available. So in the main group, in the 5 to 65-year-olds or 64-year-olds, we have 4 standard dose quadrivalent products available: the Fluval Tetra, Fluzone Quadrivalent, Flucelvax Quad, and Afluria. We have all 4 of those products, as well as 2 additional products in the 65 and older group: the Fluzone High Dose, as well as Fluad Adjuvanted Trivalent. So this is, again, not our first season using the cell-based Flucelvax vaccine. This is a product we have had previously in Ontario. As a reminder, it's been around for a while, since 2007 in Europe, as well as 2012 in the United States. But the main difference this year is that last year it was only approved for those aged 9 and older, whereas now we have a new authorization that we can use it from 2 years old and over. So you'll see before that the slight differences that make it a little bit complicated to know if you have vaccinating in the youngest age groups, that there are only 2 products available in the 6 months to 1-year-old age group, that 3 products available for 2 years and up, and then that Afluria is only available for the 5 and up. So again, just as a recap from last year, in terms of those still a little bit unfamiliar with the Flucelvax product, the benefit of cell-based vaccines is that they don't promote the same egg-adapted mutations that can occur within egg-based vaccines. That this is now available for 2 years and older. No concerns using it in people with dog allergies, given that it's grown in the canine cell line, can be given to pregnant women. And then as a reminder as well, that even though even egg allergic individuals can get egg-based vaccines, and that's not a contraindication to getting any of the vaccines. So specifically for this year, we have a couple of choices for those in the 65 and over age group. We actually have 2 products that are specifically only authorized for 65 and older. We have the high dose quadrivalent product, which contains the quad, so 2A as well as 2B products, and has 4 times the hemagglutinin concentration, so 60 micrograms instead of the standard dose quadrivalent, which has 15 micrograms. And we also have an adjuvanted trivalent vaccine, which only has the 2A and 1B instead of 2Bs, and contains the adjuvant product. And as well, if you have all of the other standard dose quadrivalents can also be used within this age group. So this year, the National Advisory Committee on Immunizations recommendations for a preferential product include that high dose quadrivalent should be used over standard dose quadrivalent in this population based on the burden of influenza A activity and good evidence of better protection compared to standard dose quadrivalent in 65 years and older. So if you have a patient in front of you and you have the choice of high dose versus standard dose, then definitely would be preferred to get the high dose for this population. NACI does not have any preferential recommendation for the adjuvanted trivalent product. There's insufficient comparative evidence on efficacy, effectiveness, and immunogenicity of the adjuvanted TIV compared to standard dose TIV to be able to draw a conclusion. But also timing is important. So if you have a patient in front of you, in the absence of any specific product being available, any of the available age-appropriate influenza vaccines should be used. So any of the 6 can be used within this population. And just as Reinders, we've sort of mentioned a few times already that it is still important to be vaccinated this season. I think certainly people felt it was important to be vaccinated last fall, although we didn't actually end up seeing much influenza, just given the amount of social distancing that was still happening within our population, the amount of reductions in personal interactions we saw and low influenza circulating. However, I think we have good indication now that those measures have shifted given the relaxation of a lot of public health measures throughout the COVID response from last fall until this fall, and that we already are starting to see other respiratory viruses circulate. We also want to make sure that people are vaccinated to decrease any pressures on the healthcare system. Given that we are still now currently within a 4th wave in Ontario for COVID activity, anything that we can do to help make sure that we're keeping people out of hospital for other reasons is important. And influenza vaccine is certainly a way to keep those most vulnerable to severe impacts of influenza, keep them healthy and hopefully out of hospital. As well, we could see that sometimes there could be co-infections. We're starting to see other viruses circulate as well. So we certainly wouldn't want to have a situation where somebody was both co-infected with influenza and COVID, or RSV and COVID, as that might increase severity or worsening outcomes for that individual. So again, things we can do to immunize ourselves against influenza would be helpful in preventing that risk of co-infection. And if you haven't been vaccinated for COVID already, don't forget your COVID vaccine as well. And so now, last piece will be just to recap on the use of antiviral medications for the 2020-21 season, 21-22 season. So we have the same product suite available in terms of antiviral medications, mainly neuraminidase inhibitors. However, they block exit of virus from respiratory cells, prevent further replication of the virus, and they can be used for both treatment as an individual level as well as prophylaxis at an outbreak level. And the main thing about antivirals is that using them as soon as possible is important. So generally, we don't like to wait for laboratory confirmation when influenza is circulating, because getting the antivirals on board as soon as possible is what makes the treatment most effective. There are 3 products available. The most commonly used product would be the oseltamivir, which is the oral product, as well as zanamivir, the inhaled product, and peramivir is an intravenous product. So typically we would say, how do we know when you would want to use antivirals? So is influenza circulating in your community? Does your patient have symptoms compatible with influenza? And is your patient at high risk for complications of influenza? Or is that person more moderately to severely ill with influenza or being hospitalized influenza, where treatment influenza would be most beneficial? Although this year it may be even more complicated to truly assess those first 2 questions, because we're probably anticipating, even if influenza is circulating, we certainly would still expect COVID to be circulating as well. So knowing just how much influenza is circulating with your community can be more challenging this year. And also knowing, does your patient actually have symptoms compatible with influenza, or is their symptoms actually related to COVID or one of the other respiratory viruses? So to help out both local clinicians as well as local public health units interpret, just where we are in terms of the season, the Public Health Ontario Laboratory weekly report does provide information by the public health unit level to get a bit of a picture as to say how much influenza is circulating within your local region. So on the table 7, we have it by health unit. We have the total numbers of specimens being tested weekly for influenza, and then the positivity for influenza A and influenza B. So sometimes when you have low numbers of tests, it can be hard to interpret just how much influenza is circulating. So generally, you would probably want to at least see, a good 15, 20 specimens being tested within your region to get a good picture as to say how much influenza might actually be happening within your region. As well in that report, we also do a breakdown by setting. So where influenza is being detected, is it from some community examples, institutions, ER, hospitalized, or ICU, to get a little bit of a snapshot as to say where that severity of the different viruses is occurring. So for those being treated for antivirals, typically this could be considered for those adults 65 years and older, pregnant women or women up to 4 weeks postpartum, those with underlying medical conditions who had risk of more severe complications from influenza, as well as long-term care home residents. And for long-term care home residents, it would be both the individual treatment for those ill with influenza, as well as for prophylaxis to help control outbreaks of influenza. We do have several resource products available on the Public Health Ontario website in terms of information for healthcare providers on how to use antiviral products, both for treatment as well as for prophylaxis and outbreaks. And we also have information on antiviral medication use in congregate living settings. So other congregate living settings that may not typically be places where we would have identified influenza outbreaks previously, maybe settings now this year, just because given all the COVID surveillance where we might be identifying influenza outbreaks, they may or may not be the type of setting where antiviral prophylaxis might be available. But if it is a setting where antiviral prophylaxis may be considered, then some of these resources have information on how to use antiviral prophylaxis within that setting. As well, we have updated some other products available on the Public Health Ontario website in terms of the antiviral products, the influenza vaccine products, as well as other resources for congregate living settings and long-term care. And now I will turn it over to Jonathan.
Thank you, Michelle. Good afternoon, everyone. So just to get us warmed up for the second part of the session, I'm just going to start off with a polling question. So we can go to the next slide and get that question up. So the question is, which two non-SARS-CoV-2 respiratory viruses have been most commonly observed in Ontario during August and September this year? Okay, yes, so shows that you guys were listening to Michelle's section. So that's correct, it's rhinovirus and parainfluenza. Of the two, rhino is something that we pretty much expect. And as Michelle mentioned, the parainfluenza does appear to have come a bit earlier than expected. We are also starting to see some RSV, in particular in Ottawa, where it has increased in the last couple of weeks, and keeping a close eye on that. So I'll just first just go through the different tests that we have at PHO laboratory. Most of you hopefully are familiar, but for others that aren't actually ordering tests, this should be helpful. So we have a standalone SARS-CoV-2 PCR when we're just testing for SARS-CoV-2. Then we have an assay that we refer to as Fluvid. That was introduced at the end of last year, so that can test for influenza A, influenza B, SARS-CoV-2, and RSV. And then we have our expanded multiplex, which you can see here, tests for the flu, the COVID, RSV, paraflu, adeno, rhino, and entero, and the human metapneumovirus, as well as seasonal human coronaviruses. We can't actually differentiate the RSV A and B, or within the coronaviruses, or within, sorry, the seasonal coronaviruses or the parainfluenza viruses, but it will detect them all. And just making it clear that this seasonal panel would not cross-react with SARS-CoV-2. Next slide, please. So at the end of July, we made some tweaking to testing algorithm and panels. During the height of the pandemic, towards the end of last year, we dialed back using our expanded multiplex assay, which we refer to as MRVP, when it was indicated, and just ran the Fluvid assay that had the flu, RSV, and COVID. But at the end of July this year, anticipating more need to have more information about what is circulating, we reintroduced that expanded MRVP at PHO laboratory, and then expanded the eligibility to allow testing for children under the age of 18 seen in emergency departments. I'd like to stress this was not done like for clinical management, but really done to help improve our respiratory virus surveillance. We'll be tracking the requirement to keep doing that as the season evolves, because we are seeing that we're getting quite a lot of submissions now, and it is helping us fulfilling those surveillance needs. And so we're welcoming samples from children under the age of 18 seen in the emergency department. Historically, most of you would know that we don't normally accept specimens from patients seen in the emergency department, and that restriction still applies to adults. And then the other change that we did was instead of running Fluvid for the other subgroup of patients that we did more than just COVID, we then reverted to doing the expanded MRVP assay. So that was any hospitalized patients, any patients being tested within outbreaks, and patients tested in institutions as sporadic cases, so not in outbreak, associated with acute respiratory illness. And we're very liberal with that, in that when we say institution, we're referring to places such as long-term care home, retirement homes, correctional facilities, could be shelters, or other group living homes, group living situations. What we don't include in that is schools and daycares. So they would not be, like sporadic cases from schools and daycares would not be sort of accepted routinely, as this could be a very large number of specimens coming in. We definitely consider doing testing if it's requested as a single request. We are happy to discuss that, and we'll do it if it's felt to be useful. Next slide, please. So here just shows like what combinations of assays we're using. So depending on which of the PHOL testing locations the sample comes into, the testing approach could be different. If the sample comes to one of our MRVP testing locations, then we'll be running the SARS-CoV-2 as a standalone along with the MRVP. If there's going to be delay in getting it to one of the MRVP testing labs, then the testing location may run the Fluvid assay first and then forward a portion of the sample for the expanded MRVP at a second location. The reason for doing that is to get a quicker influenza and SARS-CoV-2 result to assist with patient care. The other subset that we have always accepted for testing of respiratory viruses is patients in remote communities. So for them, it'd be the same. It's the same. What I just described is basically the same for anyone who's eligible for MRVP. There's two possibilities. Next slide, please. And what I didn't stress was actually this is for symptomatic patients. So asymptomatic patients would only ever be eligible for SARS-CoV-2 testing. And then within the outbreaks, we also historically, and what we continue to do now, is that we would test up to 4 specimens from symptomatic patients routinely. Any additional ones would only be tested for SARS-CoV-2, but we do welcome queries to us when it's felt that doing additional testing will help with managing the outbreak. From our own research, we found that once you've done 4 specimens, the yield to finding any pathogens beyond those first 4 specimens, if they were all negative, is very negligible. So it doesn't really provide any additional information when you're testing more than 4 and they're all negative. And then just reiterating that that we do accept the sporadic samples from institutions. Next slide, please. And here just reinforcing that asymptomatic patients from any patient setting would only be tested for SARS-CoV-2. And that just is obviously just continuing what's always been done, at least in Ontario, where we do not do seasonal respiratory virus testing on asymptomatic persons. So it's important that the test being requested and the patient setting appear on the requisition. I'll show you some screenshots in subsequent slides just to reinforce that. If the patient setting is not provided, the specimen would only be tested for SARS-CoV-2. And if it's an outbreak or an investigation, the requisition must include that assigned outbreak or investigation number. Next slide, please. So we developed a dedicated COVID-19 requisition. We updated the name to that to COVID-19 and respiratory virus test requisition a couple of months ago. That is the preferred requisition for ordering respiratory virus testing over the general test requisition. I mean, if you use the general test requisition and provide the information we need, it will still go through, but this allows us to capture more COVID-related information that doesn't really specifically ask you to provide on the general requisition. So we can go to the next slide. So here, just reinforcing in section 7, this is where we ask you for the patient setting. Next slide. And then here, of these, obviously the most important thing is to let us know if the patient's symptomatic or asymptomatic, and if possible, provide the other information. We do have another box that any of you ordering tests, this has been on our requisitions for a while, but we do ask about vaccination status. Obviously, there is, like, PHO has access to that information through other means if it's really required, but it is helpful to get that information up front on the requisition. Next slide, please. The other update we made was we provided separate buttons where you could tick or fill in or click on the appropriate one if you're filling it in online, whereas you tell us specifically if you want COVID, just respiratory viruses, or both. This is really important more in the situation where a specimen is starting at a lab that is able to do the COVID-19 test, and we'd usually recommend that if possible they do that to provide that result as quickly as possible. But if they're having to send to another lab, say to PHOL, for that multiplex, they could just order the respiratory virus testing alone, and that way we would know that you don't need the COVID test as well. Saliva has been validated for doing SARS-CoV-2 PCR testing, but it's not suitable for doing respiratory virus testing. There definitely has been research into testing saliva, and it can be used, but in Ontario we have not validated that specimen type. So we would not be able to test for anything but SARS-CoV-2 if that specimen is used for collection. Next slide, please. And just pointing out that this is where we ask for the investigational outbreak number if that's relevant. Next slide. Just re-mentioning that feel free to contact us if it's an outbreak and 4 specimens have been tested and you would like additional testing, or if you have a patient that doesn't meet our criteria, say if it's an adult in the community, we're willing to discuss, and we have a low threshold to approve testing outside of like what is our formal algorithm. It's very rare that we say no, but we do ask that you reach out and ask to send the specimen in so we can warn our lab that it's coming. And if you're ordering anything besides COVID or seasonal respiratory virus testing, we would ask that you do add a general test requisition. So if you need like mycoplasma done as well, it'd probably be advisable to add a general test requisition. And obviously if you're sending in any other samples. You can request any testing outside our usual pathway by contacting our customer service center. And the numbers here, and will be in the slide deck when it's posted. Next slide, please. So all information that I've just given you is contained in our respiratory virus test information sheet. We usually release a lab abstract. For those of you that know what lab abstracts are, that would be a formal, like sort of letter type communication that goes out. But for this year, we've put it within our test information sheet, and that way it can be updated more easily as required. So feel free to go there, and there's a bit more information than what I went through. And that's on our website for you. The next slide, please. As Michelle mentioned, these are the two PHO reports that help you know what is circulating in your community, and particularly making decisions about empiric influenza antiviral therapy. This information is very helpful. So we have the Ontario Respiratory Pathogen Bulletin. And then we have the lab-based respiratory pathogen surveillance report. That was the report where Michelle showed you the viruses by age group and by public health unit. We have also just recently updated it, so we don't only show influenza by health unit, we show the common respiratory viruses. So right now we're showing, for example, rhinovirus data by health unit. So we think that could be very helpful information to see what's happening locally for the non-COVID viruses as well. Next slide, please. And just reminding you that we do have a lot of COVID-19 resources on our website. A report that some of you might not be aware of is that we also are producing now a weekly whole genome sequencing report that provides you all of the lineages that are coming up in sequencing. That combines the data not just from PHO lab, but also the other genomic sequencing labs in the province. Next slide, please. And this is showing you the other key reports, such as the daily and weekly COVID-19 epi reports. And on the previous slide was the data tool where we provide daily information. Next slide, please. And a final reminder that we do continue to offer testing for things like novel influenza, antiviral resistance testing, MERS-CoV, and enterovirus D68, but I won't go into any more detail on those. Next slide. So as you could probably imagine, like any of this work around respiratory virus testing, particularly at this time in our history, requires input from a whole lot of people. I'm not going to name them, but these are some of the individuals that have made a big difference to all this work we're doing. And then many of our partner agencies and the Ministry of Health also are key collaborators in all the work that we do. So just for the last slide, if anybody has any queries about the presentation or any questions that come up after the session that you want to ask, you can email them to this email address, epir@oihpp.ca, and we'll work on getting you a response. Okay, so I'll hand back to Andrea now.
Okay, thank you so much, Michelle and Jonathan, for a fantastic presentation. We'll now move to the question and answer period. So if you haven't had a chance yet to enter your questions, please do so now in the Q&A pod at the bottom of your screen. And as Jonathan mentioned, we'll do our best to get through as many questions as we can. But if we don't have a chance to get to your question in the time we have remaining, please email them to epir@oihpp, and we'll do our best to respond by email. So to start off with, we do have a couple of questions related to testing. So with regards to testing of influenza last year, were the number of tests being conducted comparable to the previous year? And along the same lines, is it possible that the reason of low influenza cases could be related to a decrease in testing for influenza with more emphasis on COVID testing?
I could start, and Michelle, you might want to add. I would say I'm sure we did less influenza tests, but I haven't actually looked at the numbers side by side. But we still did a lot of influenza tests. I think Michelle showed you that. Like, I think we got up to like 1,000 a week in some weeks. So I wouldn't, there's no way we could explain the extreme absence of influenza on a reduced number of tests that were done. You know, like at the peak of flu season, our positivity gets up to 30 to 40% every year for at least a couple of weeks. Whereas here, yeah, the numbers that were seen were like in the, like, I can only recall a couple positive within our lab system, to be honest, but there must have been at other labs. So this was definitely a phenomenon, and this has been described in multiple jurisdictions throughout the world. So I think this is a phenomenon. I don't have a clear explanation for it, but apart from definitely the IPAC precautions that were put in place must have had a big impact, but I believe there must be some type of interaction going on that we still don't totally understand. And also just like the fact that we're now seeing waves of the other viruses coming back at the wrong time. I don't think we totally understand yet biologically what drives that, but it's a very interesting phenomenon to observe at least.
Okay, thank you, Jonathan. There's a question about RSV, and can we explain the interseasonal surge of RSV infections? And could it be related to increased vulnerability among young people, given the last 18 months of strict masking and hand hygiene measures?
Yeah, I think as Jonathan mentioned, I don't know if we totally know all the reasons why RSV has emerged in this interseasonal time in the way that it has. I think there's a pretty good investigation that happened in Australia that had one of their early interseasonal outbreaks. And you know, one of their large outbreaks, the RSV that was circulating is actually not something that they've ever seen before in Australia. So it was really kind of still unclear to them, you know, how did this RSV even enter at a time when there was very strict international travel restrictions for coming into the country, strict lockdown measures in terms of COVID precautions within the country. And yet that, like, once it actually took hold, because really nothing else was circulating, it actually spread very quickly within that urban environment. So I think that that's, you know, probably our best guess as to what might be happening now. You know, we haven't really been exposed to it. So when RSV does get introduced into the right kind of densely populated environment, particularly amongst young children that might be mixing, I think we would expect it to circulate relatively quickly, even if it is an interseasonal time, just because of, you know, there's not really much else to compete with it in terms of what's going on. So I don't know if we know all the factors about exactly why that's happening, but I think it's certainly a phenomenon that we're seeing internationally.
Thanks, Michelle. So now we have a few questions related to vaccines for the influenza season. So the first question is, based on the National Advisory Committee on Immunizations recommendations, should the quadrivalent high-dose vaccine be used preferentially over the trivalent adjuvanted vaccine for those over 65?
Yeah, so NACI doesn't have a specific comparison or preferential recommendation specifically against the high-dose quadrivalent product versus the adjuvanted product. The only preferential recommendation from NACI is specifically the high-dose quadrivalent compared to standard dose. So if your options were standard dose versus high dose, then absolutely go ahead and give the high dose to that 65 and older population. There isn't a preferential recommendation for the use of the Fluad, the adjuvanted product, compared to either the high dose or even standard dose product. So really that could be thought of more interchangeably. It's just another product that you might have available to offer to seniors, but there is no specific preferential recommendation for that product.
Thank you. Next question is, will there be, for any of the vaccines that are available this year, will there be an intranasal format available? And if so, will they be prioritized for younger individuals or available to anyone at request?
So the intranasal, the FluMist, which a product that many people would be familiar with for young children, is not part of the Ontario Universal Influenza Program this year. So we're not anticipating any publicly funded doses of the FluMist for this year.
Okay. And a final question about vaccines. Given that we had very low levels of flu circulating in previous years, how effective do we expect the annual flu vaccine to be this coming year based on strain?
Yeah, I don't think we have a lot of information to really to comment, because we don't know what flu will be circulating. So we don't really be able to say how well does what's in the product actually cover what we might actually be seeing. So I think that's a bit of our blind spot right now coming into the current season, is we're a little bit unsure, just what we're going to see and how well that vaccine might work against it. I think that one of the things we might see though is that typically we would have a season where it's either an H1 season or an H3 season dominating, and then typically later in the season an influenza B circulating. I think one of the other unknowns is, is that still going to be the pattern of influenza that we see, or we might see a bit more of a mix? Could it be a number of different variants being reintroduced? So I think it's going to be a lot of new factors and something we're going to watch closely as the season unfolds.
Great. Now we have a couple of questions related to antiviral use. So given the difficulty in distinguishing between COVID-19 and influenza early in the clinical illness, are there any downsides to providing antiviral treatment to someone who may end up having COVID-19 and not influenza?
Yeah, I think that's a good question. I mean, I think at any time, ideally we would not give a medication to somebody who's not going to benefit for it. So giving something to somebody where an antiviral is not going to have any impact on their COVID illness, it's really going to only work on their influenza if they have it. So I think, going back to that beginning of when is it good to maybe go ahead with that antiviral, if you're in a circulating situation. So as Jonathan mentioned, in a typical influenza season, we may see as much as 30%, 40% positivity for influenza or some of our peak weeks. So if you're in a region where we're at that kind of level of high influenza circulation, even more than 20% positivity, it's generally recommended to say, if you see someone with that a more classic influenza-like illness presenting and they have a high risk of severe outcome for influenza, then there would be benefit of going ahead and starting them on that antiviral even before confirmation of that influenza infection. And yes, there may be a downside that they might have to stop it. So if that came back and said, actually, no, you don't have influenza, you had if they did subsequently get tested and they actually had COVID, then you may have to stop that medication for that individual. But certainly if they had influenza, starting it early would be a benefit. But really getting that right timing of, is this the right person who's going to benefit from antivirals? And is it likely that is what they actually have given what else is circulating?
Okay. And along the same line, in the event of an influenza outbreak in a long-term care home or retirement home, should individuals have their creatinine levels checked prior to having standing orders for antivirals?
So I think this is a kind of perennial question that we get, and the answer is no, you don't have to do routine assessments of creatinine. So the renal dosing for the antiviral products is really only for those who are known to have known renal impairment. So somebody who is already on renal dosing for other medications is the kind of person that you would use a renal dosing for an antiviral. If for some reason you have a patient who, that's not known, there's not a reason to do necessarily a creatinine ahead of that. So there's no indication for doing routine creatinine across the board for patients or residents in a home that might be getting antivirals as prophylaxis.
Okay, thank you. So next we have a few questions related to testing and the testing algorithm and requisitions. So the first question is PCR being used for any other viruses other than SARS-CoV-2?
Oh, hi. Yeah, sorry if it wasn't clear enough. All the tests that I referred to are using exactly the same technology. It's real-time PCR assays, the FLUVA, the MRVP, the expanded assay, so it's all by PCR. And I got some questions in the chat box about saliva. To make it clear, PHO does accept saliva for SARS-CoV-2 testing, and we don't, neither does any other lab in the province, test saliva for the seasonal respiratory viruses. So hopefully that's clear.
Thanks, Jonathan. And there are a couple of questions. Could you just clarify again what viruses are covered in the multiplex versus the fluid, and how you identify which specific respiratory virus is found in the specimen?
Okay, yeah, so they're both, these are panels that can test for multiple viruses. I can't go into how the technology works, but we do have some documents on our website that I can post a link to. But basically, they have targets for each of the different viruses that are in the panels, and if they're positive, if they come up positive, then we know that's the virus that's in the sample. The fluid can test for influenza A, influenza B, RSV, and SARS-CoV-2 in one well. The expanded multiplex that I refer to as MRVP can test for influenza, RSV, adenovirus, seasonal coronaviruses, enterovirus, rhinovirus, and human metapneumovirus. But all of that will be in the slides, and it's at our on our website at our respiratory virus test information sheet, which will also we'll have links for it, but you can even just Google it and you'll find it.
Okay, thank you, Jonathan. A question about the requisition, and if you have a resident, presumably in a long-term care home or retirement home, who has 2 or more symptoms of a respiratory illness, should they be checking off requesting testing for both COVID-19 and respiratory viruses on the same requisition?
Yes, we would advise that. You have sporadic case in an institution. If they're symptomatic, then we encourage that they be tested for both respiratory viruses and COVID up front. The important thing to know is that due to the overwhelming number of samples coming into lab, specimens that are negative for SARS-CoV-2 are often discarded now within a day or 2 of testing. So it's really hard to be able to go back and, like, if you contact the lab after you get the result for COVID being negative, there's a high chance that they won't even have it anymore in the current situation. So it's really important to just order it up front on the sporadic cases.
Okay. So I think we may have time for 1 or 2 more questions. So there are
Andrew, maybe we could just, there's been a number of questions about co-administration, so whether you can give flu vaccine and COVID vaccine at the same time. So maybe I just jump in there because I've answered a couple in the chats, but that we are anticipating the NACI guidance on this to be released later this afternoon. So hopefully that updated guidance will be able to answer people's questions about giving COVID vaccine and flu vaccines around the same time.
Okay, great, thank you. And I see there's also a question about should you wait for a negative COVID-19 test before starting antivirals?
I can take that one. I mean, as a clinician, and I typed an answer already, but basically it's similar to like pre-COVID. We did not allow testing in the ambulatory setting, and we advise that if flu is circulating to treat empirically, even though we know that a portion of patients would have had other viruses such as RSV or rhinovirus. Here it's exactly the same. We know a portion might have COVID and that we're treating them, but the antivirals are most effective in the first 48 hours of symptoms. So, and by like waiting for those results, that their effectiveness just drops off significantly. So we would not advise waiting for the results.
Okay, thank you. So I think that's all the time we have for questions. So as we wrap up today's PHO round session, I would like to thank Michelle and Jonathan for presenting. I would also like to thank everyone who has joined us for today's session. It's so great to see such a strong virtual participation during what is a very challenging time for healthcare professionals. In the coming days, you can expect to receive a brief and anonymous survey for today's PHO round session. Please try to complete this to help us improve our programming. Lastly, to access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. And as mentioned earlier, if we didn't get a chance to answer your question, please email them to epir@oahpp.ca and we'll do our best to respond. Thank you, everyone, and please have a wonderful rest of your day.